Good morning and welcome everyone to a webinar hosted and presented to you by the O'Neill-Lancet Commission on Racism, Structural Discrimination, and Global Health. My name is Sarah Bosha, Director of Health Law Programs at the O'Neill Institute for National and Global Health Law at Georgetown University. Today, we are discussing the topic Artificial Intelligence, Technology and Health, examining inequity in access, racism, and structural discrimination. I have an esteemed panel of guests and experts to be able to help us unpack and understand this issue, and I'll share with you some of their accomplishments. One of our first panelists is Dr. Priya Balasubramaniam. Dr. Priya is a public health leader with 20 years of experience in shaping health systems in South and Southeast Asia, Africa, the United States, and Canada. She's the director for the Center for Sustainable Health Innovations in Singapore and India, and leads the tripartite Innovations for UHC collaborative focused on South-to-South dialogue for low-cost technological innovations and new models of healthcare in Asia and Africa. She's also a senior public health scientist at the Public Health Foundation of India, where she directs the Universal Health Coverage Initiative, part of one of India's seminal health policy exercises on health system reform. Our next panelist is Dr. Jeffrey Sewell. Dr. Sewell is a research assistant professor at the University of Michigan Department of Learning Health Sciences and a research associate at the Michigan Center for Global Health Equity. His research integrates fundamental biology with computational approaches such as AI, and systems biology to drive equitable advances in drug discovery and clinical medicine. Previously, Dr. Sewell was a research assistant professor at the University of Notre Dame and a research scientist at IBM Research Africa. He is a founder of several technology startups, including Helix Nano and Anza Bio. Paula Akugizibwe is a public health professional trained in pharmacy and epidemiology with over 15 years of experience working in health systems in a few African countries. Over the past 3 years as a digital health consultant with FIND, a diagnostics-focused institute, she has worked closely with ministries of health and other partners on operational research focused on using digital technologies to increase accessibility, quality, and efficiency of diagnosis. Her previous roles also included coordinating research at the University of Cape Town, in which digital tools were used to better map the epidemiological impact of gold mining on TB and silicosis among miners and ex-miners in Southern Africa. She's also a writer and editor and is based in Kigali. And finally, our expert from the United Nations is Dr. Tlaleng Mofokeng, the current UN Special Rapporteur on the Right to Health. She is the medical director of the DISA Clinic, a women's health clinic in Johannesburg, and a senior lecturer in gender, culture, and HIV at the Africa Center for HIV/AIDS Management at Stellenbosch University. She's also a distinguished lecturer at the O'Neill Institute for National and Global Health Law at Georgetown University Law Center, where she teaches on decolonization in global health. I'll hand over now to Dr. Mofokeng to give us the opening remarks and frame our discussion.
Hi, Sarah. Thank you so much. Just wait for me if you can hear me well. Of course, thank you. In the spirit of digital justice, I'm connecting from Joburg, and I must just apologize that I'm not on video because of electricity and data challenges. So I think this webinar is quite timely, not only for the content, but the reality of having to do this work as well, as practitioners. I just want to give a bit of a history perhaps and an overview that in fact I started part of my recent career on online spaces, particularly Twitter, almost 12, 13 years ago now, where there were no policy guidelines for medical doctors on how to use social media. And I was using that space to talk about sex positivity, to talk about health and wellness of women, but also talking about issues such as sex work and sex workers' rights, and for example, women having sex with women, and making online spaces safer for us, because we found that even in real life, we actually couldn't have these discussions with our medical practitioners. And so that's just an interesting part of my story about why my interest in digital health. I've also designed and developed an health e-app called Sintibale during COVID. That was intentional for me, that by the time I write this report for the UN on digital health and technology, I have some exposure and understanding to what it actually takes to build some of these solutions and digital tools. And so again, knowing that this year it's the 75th anniversary of the Universal Declaration of Human Rights, and the Secretary General of the UN has spoken and recognized digital technology to be able to advance universal health coverage. It was imperative for me to propose to the multilateral system, to the UN member states, a human rights approach that underscores the interrelatedness and the indivisibility of human rights. The fact that as we think about universal health coverage, as we try to accelerate, meeting the agenda for 2030, we understand that human rights are important for prevention, they are solution orientated, but they are actually foundational in advancing the peace, security, humanitarian, and developmental agenda. And so with COVID, we saw how many countries around the world and how many health systems were able to incorporate telemedicine and using tools to track and monitor in a way that before the pandemic was met with a lot of resistance. And so there's no doubt that the growth of innovation has been rapidly defining and reshaping the right to health. And so it's important, again, to be able to assist governments and member states to understand how, in the operationalization of the right to health, in using digital tools, how it is important that to keep in mind artificial intelligence, to keep in mind the entire data pipeline in terms of design, in terms of the discrimination, right, that can go into coding, in terms of accessibility and availability, and whether or not those tools will, after all, be accepted by the communities, because we know there is a big element of trust, right, that has to be existing in order for the health system to work. And by introducing digital transformation in primary health care, to what extent are we actually, increasing acceptability, but ensuring quality? The other thing that was important is, of course, that the adoption of these technologies should not lead to a divestment in underlying determinants of health, in medical facilities, but also particularly serving vulnerable, at least populations in vulnerable situations, such as those in rural areas, migrant populations, asylum seekers, LGBTIQA+, and gender diverse persons, Indigenous persons, and older persons as well. And I think it was important to highlight Indigenous people and older persons because of the concern around digital literacy. A lot of the times there's an assumption that everyone is comfortable with a cell phone, is comfortable with downloading an app, and is just comfortable with interacting in this way around their health and wellness. And some assumptions can actually lead to a decrease in access for many of these communities. It was also important, at the back of the report I had done to the General Assembly on racism and the right to health, to also foreshadow the fact that digital tools themselves can perpetuate racism, sexism, ableism. And in fact, for the populations, those discriminations are already so severe in real life, and there's already no accountability for in real life or offline violations, and that those same injustices, discriminations exist online as well. And to what extent do member states and all stakeholders understand their role in accountability, but in protecting human rights? And so part of today's idea is to start doing the work towards design justice and digital justice, in which we have a diverse group of people in the processes to meet diverse needs of people in the local sphere. Today is the start of many consultations, but I think the report that it was just presented to the council provided us just one moment to be able to use as a stepping stone to have many other important conversations. And I just want to say, one of the things I speak about in the report, which is something that's really, really worrying, is that in certain circumstances, you have companies and other public sector bodies who are being compelled by law enforcement bodies or courts or prosecutors to hand over personal data for criminal investigation and prosecution. And last year and towards this year as well, in my role as the UN Special Rapporteur, I actually was very vocal in supporting the rights of an activist in Poland who was being criminally charged in court for assisting someone get a medical abortion. Just yesterday, in preparation of this webinar, I saw that in the US, there's actually a mother and a daughter who are currently both being prosecuted because Meta was compelled to give this data to the courts and to the prosecutors, and they are being charged, of course, in a state that has then post Roe v. Wade has criminalized abortion care. So the idea of mobile communication, geomapping, people search history data being used as evidence against them compounds the existing inequality. And so as much as digital technology is not all bad and not all good, it is important, of course, to recognize the multifaceted experiences, but really start to think about what is the policy approach to the operationalization. What is the human rights-based approach that centers the human and the rights holder, and that they are always informed about their rights, that we support them with digital literacy, that they have the entire digital pipeline accountable, including states and non-state actors, and how do we then ensure that there is some form of independent data and privacy oversight bodies to ensure that everyone is doing what is expected of them. I haven't even gone into the clinical setting, but that's just for me a context of where some of my history is, some of my work has been, and why this report was important. And I look forward to hearing from all of you. And thank you very much to all of our panelists for joining us today. So I will be quiet and I'm eager to hear and listen. And thank you so much to all of the people who've also joined in, I know from all across the world as well. Thank you, Sarah. Over to you.
Thank you so much, Dr. T, for those wonderful framing remarks. And to the experts, I'm going to throw this question out to you just as a way to give your experiences and your understanding. How do technologies, digital innovations, and data widen the gap of inequity in health? And how can we really achieve digital justice? I'm going to hand it over to Paula first to start us off, and panelists, please just feel free to come in as you feel.
Sure, thank you. It's great to be here with all of you today. Thank you, Dr. T, for that really interesting introduction, and hopefully everyone on the call has read the report. If not, please do. Lots of interesting things coming out of there. I would like to clarify that I don't consider myself an expert in most things, but certainly very happy to share some of the experiences and observations. And maybe I'll kick off by saying that I think the dynamics that we see as far as digital technologies are concerned are not unique to digital technologies. They're common in many examples across various aspects of the global health sector. I think any sector sort of replicates the biases that we see, as Dr. T mentioned just now. Digital technologies can compound existing inequalities and contribute to those. One of the obvious ways in which that manifests is through what is commonly referred to as the digital divide, meaning that certain groups who have more access to digital infrastructure will then, once that infrastructure becomes the channel through which services are deployed, will then also have more or less access to health services. And so the underlying imbalance isn't addressed. I think another example, I'll just share two examples. One that really encapsulates the problem quite well, that was shared by a colleague of mine, Dr. Matthew Arends, I don't know if he's on the call, who works in medical AI, is one of the challenges with medical AI is the way that it's skewed towards certain groups. So the way that, for example, computer-assisted diagnosis works in one population will not be the same as how it works in the other, because it tends to be more accurate when you're dealing with a middle-aged white man. The way that transdermal reading devices work is tailored more towards white skin. And we've seen this again for drugs, where the study populations tend to benefit certain groups more than others. And then some initiatives to try and address this, like a validation platform that's being set up by and others, to enable people to really calibrate and evaluate AI technologies for the local contexts, is also limited by the fact that in many what are so broadly and often dismissively referred to as LMICs, but the countries that are the target of these technologies, there's also less access to infrastructure, for example, for storage of data, of images that are used to evaluate how good the technology is in that context. So even the ability to develop better technologies itself is undermined by the larger structural inequalities that we see in our national and global societies. I'll stop there. I'm sure that other panelists have many more examples to share, but certainly I would say that the gap of inequity in health will be widened by any technology that doesn't proactively and consciously consider how to narrow that gap before deploying any interventions. Back to you.
Thank you so much for that insight, Paula. I just want to pick up on the point you raised about how technology is, I want to say, deliberately created, or is created in such a way that it attends to the needs of, or is attuned and programmed to the needs of one particular group, for example, white middle-aged men. How do we overcome that, or how does that happen? And I throw this question to Dr. Priya or Dr. Jeffrey, if you want to come in and respond to that question. How do we get to a place where we're creating technology for health that seems to only be effective or accessible because of the way it can be used for only one group?
Well, I guess I'll come in. Thanks, Sarah. That's an interesting question. And, there are three ways. I mean, technology from an accountability perspective is often a double-edged sword. On one hand, it has allowed tremendous access to those who may not otherwise have access to certain types of services. It has eased bureaucracy. It has enabled certain types of gaps to be filled within health systems that may have not been otherwise enabled. It has enabled us to respond better to emergencies, whether it's through surveillance or towards, say, creating better access to non-communicable diseases. But on the other hand, it can also, if unchecked, have huge issues with privacy, with misinformation, with the use of large data sets, and the manipulation of artificial intelligence through the variation of these different algorithms and the biases that they produce. So one area I think that we need to think about, or three ways in which we need to think about the technology or digital health ecosystems, as they are now called, is that technology has to be viewed as a social determinant of health. It has to be viewed as a commercial determinant of health, and it also has to be viewed as a political determinant of health. So coming back to your answer about, can we create a new kind of regulation or stewardship of technology that eliminates some of these biases or inherent profiling, or technology that is universally accepted to all? And that all comes back to that question I think you and I were talking about at the beginning, which was about technology design. And a large part of how we view technology also has to do with who is designing these technologies and for whom. So I'll just throw a couple of numbers. The current global digital health market in this world is $233 billion. In a country like India alone, which is a leading country from the global south, there are about 7,194 digital health startups, counting. a lot of countries now are looking at digital health diplomacy as a way to interact with each other through interoperable architecture and platform. So unless we begin to look at who is designing technology and for whom, and how they are enabling that design to happen, who are the stakeholders that are being involved in that design, this is going to be a widening gap in the way technology is being used as well as abused. Let me give you a small example. So more recently, and this is so timely because I work with a legal entity of a legal firm in India called Ikigai Law that does a lot of work around digital health laws and the emerging laws in the country. And they gave a very interesting example of a particular health technology platform in India called Practo, which actually was brought to the attention of the Court of the Chief Commissioner of Persons with Disability as part of a lawsuit. And this was because Practo, which is essentially a telemedicine platform, was and requires a certain fee for service sign up. So this had a person with disability actually sue Practo for saying that he signed up to a telemedicine platform that was not intuitive for a person of disability. So if you are looking at an increasingly digitized world where digital services are going to be the norm rather than the exception, then unless you incorporate a variety of stakeholders in the design phase of digital, there is going to be a challenge. I'll stop over here, and I'm sure there are others who would want to weigh in on this. Thank you.
Yeah, thank you for that, Priya. Jeffrey, I know that you've worked quite a lot on the design end. So tell us what are the challenges and how can we overcome these challenges and achieve design justice?
So thank you, Dr. Priya, and thank you, Sarah, for having me in this panel. Actually, it's very enlightening for me because I come from the back end, so doing research on AI and developing prediction models that are based on AI. And I think one of the lessons right here for me is that, in the AI world, there is a lot of discussion around responsible AI and how to develop these technologies responsibly. But actually, one of the things that is lacking, which I've really learned from the report coming from the Special Rapporteur, is this need to center digital technologies on human rights. And I can say that in many of the responsible AI discussions, this issue of centering these technologies on human rights is actually lacking. And I think this is a problem of not having all the stakeholders on the table. So being a researcher myself, like researchers, we don't think about this issue in terms of human rights. We actually think about them more in the terms of how can we make our research, for instance, more open, but not necessarily how this has an impact on the wider context of human rights to the eventual end users. So, for example, patients. So this is really lacking, and I think having like the diverse stakeholders from the beginning is important. So diversity in terms of the composition of those teams involved in developing digital tools, diversity in terms of the expertise, in terms of the gender, in terms of the race. I think we need all of this diversity from the beginning. The other thing I want to say is that my biggest fear with digital technologies, and this is also true in other areas I work in, such as gene-based technologies, is that these technologies are changing very rapidly, so they are exponential. So while these technologies, of course, reproduce the imbalances that already occur in our society, I think the biggest fear is that these technologies are changing so rapidly that they might actually exacerbate the inequalities just by the nature of their cascading effects. So, for instance, if you take the case of access to data from diverse populations in clinical trials. That if we don't have diverse clinical trials to start with, then we end up with either medications that do not work effectively in certain populations, and this has an impact on the medical outcomes in those populations, and then that has, cascading effects on the entire population, and it becomes very hard to track the impact of these inequalities. So I really believe that having the stakeholders from the start to come from diverse backgrounds is really important. Yeah, so I'm really glad to be in this panel because I'm learning a lot from the panel, and from the report is calling for me really to think about this issue of human rights and digital technologies.
Thank you so much, Jeffrey. And I think you raise a good point about what global health is supposed to be, right? There's this floating definition that already gives us the understanding that global health is not just the clinical, it's not just, the public health experts, it's the politicians, it's the sociologists, it's the anthropologists. It really is this multifaceted field. And so just moving on a little bit more, we've sort of established the problem of AI technology and how it can exacerbate inequalities. Have we seen how, digital exploitation has been combated in poor and racialized communities? Have we seen sort of the positive side of digital technologies in helping to advance health equity, helping to give access to those that previously did not have access? And what are some of those examples that we can highlight in our work? And I'll start with Priya. If you could go first, that would be great.
Well, I think there is a lot of, understanding digital technology and the implications are only now settling in globally. I think the pace of digital technology over the last 10 years has become so rapid that we are actually playing catch up. Governments are actually, back-footed when it comes to trying to understand or regulating the sheer pace of this technology, the kind of diversity of the technology, whether it's genomic or artificial intelligence or diagnostic and screening devices or wearable devices. So I think in terms of what we are doing, I think there is, there are I'd like to kind of preface by saying that we have to begin by maybe integrating human rights or rights-based a rights-based idea into the life cycle of digital technologies themselves. Because right now, there are very few globally accepted standards for promoting or protecting human rights within digital health. So this is really kind of, I would say, the beginning of a movement. But at the same time, I don't think we are particularly far behind, because there has been a lot of rights-based activism in health systems alone. We are standing on fairly broad shoulders when it comes to addressing the rights of vulnerable groups. It is about creating a more inclusive dialogue now, taking into consideration digital and all the pros that it brings, as well as some of the risks. So I think there is I think we can begin by really starting out with creating a diverse set of stakeholders and begin to address digital conversations through citizen groups that have so far been excluded in a lot of both global as well as national and regional debates around digital. We have to begin to bring in populations who are served by those technologies into those design of those technologies. So I think we are at the cusp of something big. And because digital is such a fast-moving arc and has already so insidious in the way that we are going to approach and use healthcare, we have to take the idea of rights-based health and implant it firmly right in the center the digital ecosystem at large. Because at the end of the day, digital is only a component of health, the complexity of health systems. But it's a component that's not going to go away, and there are going to be multiple factors at play. But if we begin to view that through a rights-based approach, then that itself is the first to be able to address change right at the onset.
Okay, thank you so much for that. Dr. Jeffrey, Dr. Priya raises an interesting point about including the communities that are supposed to be served in every aspect. You are in the back end, you understand that back end. Is that a possibility? Could that work? What would need to happen for that to work? And I think, Paula, given your own experiences as well, I would love for you to weigh in on that same question and any additional information for our colleagues.
Yeah, I think there's definitely a huge opportunity for community involvement, and community here can be at the level of individual patients, or at the level of government, or at the level of even funders taking a more active role in some of the research. I think there has been good examples of patient engagement, especially for rare diseases, where patients can be engaged from very early stages of research and inform the direction of the development of the digital tools. I think when it comes to global health research, there is need for very early on, when developing digital tools, which could be, for example, digital vaccine or immunization record systems, to go into communities and involve the local communities. So in the case of vaccines for children, engaging the caregivers to see what kind of digital vaccine technologies can work for those communities. Because of course, one of the challenges with the digital technologies is that they rely on access to the internet, right? So you need access to the internet, then you need also access to hardware, which could be like a mobile phone. But with a mobile phone, for some digital technologies, you might need like a smartphone. For some, you might work with text messaging systems or USSD, which is more like an interactive interface. So if you engage like the local communities from very early on, you can figure out whether the technology is acceptable, because this is also like another issue. So even though we say that, the mobile phone access rates in the world is increasing, but of course there are like gender inequities in access to mobile phones. So we develop these digital health technologies for even a place like Kenya, where I come from. It's not always obvious that those technologies can be equally accessible across different communities, like rural versus urban areas. And if you go into rural areas, also there is also the issue of a patriarchal structure of families that might actually affect the access to digital innovations. Yeah, and yeah, I let Paola, maybe you have some additional thoughts.
Yes, thanks, Dr. Jeffrey. I think all really good points. One thing I would like to highlight, which comes back to my comment earlier about how the challenges here are quite common across the whole health sector, has to do with this idea of community involvement and what does it mean to involve communities. I think there's a tendency in public health more broadly to infantilize this group that we refer to, again, very broadly as the community, and to imagine that there is a really inherent barrier that prevents us from including people whose lives are affected by the technologies that are being developed. bringing them along the entire journey. And that's one of the reasons why I also resist the framing of experts, because actually no one is a bigger expert on my health than me, right? Even if the biomedical or the digital technology exists, I'm the person that understands the factors that will determine how I use that drug or that test or that digital app to improve my health. So I think it's absolutely critical, and health is one of the few, well, I don't know if it's one of the few, but I think it's definitely pronounced in health, the extent to which decision makers are so disengaged from the end users or the market, because also this for many operates as an industry, you know. I don't think you would see that kind of disconnect to this extent elsewhere. And so I think it's a bigger sort of call to understand when we talk about, for example, design justice and community inclusion, how can we do that in a way that doesn't see it as a kind of, you know, sub-activity within our bigger task of creating something that works, but actually sees it as central to that. And I think that where there's willingness and openness and humility, it's actually not rocket science to involve people throughout the journey, but it just requires this reconfiguring of how the health sector typically works. It requires transparency as well. And this is not to sort of undermine the technical expertise that's required for some of these, you know, technologies, but there is a great deal of transparency that could be introduced that sometimes is withheld under the guise of this being too complex, too technical. I think if you can't explain very simply what your work is trying to do in a way that benefits someone, then you should really ask yourself, you know, is this work essential? Which leads me to my third point of really starting from the problem and not from the product. One of the big challenges that I've seen, and I say this as a non-tech person who came from a public health background, but has been working in digital health, just out of, I guess, more of a focus on the functionalities and the data utilization, how that can enhance public health outcomes. The starting point that we often have is, what is the problem in the health system? And then what are the existing technologies that are already available that could be used to address this? What's the best way to do it in conversation with the people who are affected? I think there's really a need to move away from just the product-centric approach. Of course, it's important for innovation, but what often happens is people try to fit reality to the product rather than the other way around. And you'll find that there's often so many products that already exist. And while on one hand, digital technologies can help, for example, a community health worker, a cadre that is increasingly being, you know, having so many tasks shared with them, as they call it, but tend to be, for example, women who are underpaid, work long hours, and don't receive the professional recognition and compensation that they deserve for their work, as happens in so many other sectors where women are involved. Having something like a reporting tool that will prevent someone from walking to the facility every week with big files. There was a really interesting study done in Lesotho about the amount of money that it saved community health workers. And I remember asking one, how much time did you spend on reporting before this? And she said, oh, not so long, about maybe 5 or 6 hours a week. And to me, that's just staggering, you know. That's almost a full workday for someone that's not even really getting compensated. So digital solutions can help with that, but you also can have a situation where a community health worker is sitting with 7 apps on their phones that are for the same patient population within the same health system. So I think, you know, I can't really emphasize enough how important I think it is to just sort of shift the point of departure for digital technologies, for all technologies, and start from what is the problem we're trying to solve? Who are the people that, you know, need to be involved, that this is for, because they're the ones that are best placed to advise. I know I've spoken for a while, but I do want to mention a really great example of a group in Guinea-Conakry that we've been working with called Clinic O. And they are working in settings where there's very little in the way of physical infrastructure as far as health services go. There are people from those communities who just realized the only way to resolve this is by coming up with some sort of digitally enabled medical service that we can run ourselves. And I think they're a really great example of a community-centered and led project. And as much as they've developed this technology and all these services, everything begins with the leaders, whether it's the imam of the mosque, whether it's the chair of the local women's group, from the stage of conception through to execution. It's just a natural part of their business model. So it's not something they have to think about. It's been just inherent from the very early stages of ideation. And I'd really encourage, I think, all digital health practitioners to operate in the same way. Thanks, back to you.
Thanks so much, Paula. I also like this reflection that you have, that this word experts, it tends to be exclusionary, right? So some people become the go-tos and the others are, well, we're going to tell you what we know and how things should go. But I mean, I want to circle back to Priya and ask, you said India has thousands of new startups that have come. Have any of them, to your mind, and is the industry looking at things the way that Paula and some of us who also aren't technical experts wanted to be looked at, which is start your design from the problem and consultation versus you just focusing on a product that brings you profits? Is there an opening for that, and how do we achieve that if there isn't?
There is definitely an opening for that. I think it's also the excitement of creating technology that it often gets carried away in a lot of the initial debates. There's also an enthusiasm by governments to want to fund startups, and the development sector and the funders follow suit. But at the end of the day, as many of the other speakers here have said, it's a law of natural causes. There will be some that are intuitive and that work well, and there are some which are counterintuitive are going to fall by the wayside. So in this very kind of thriving startup culture and digital culture, there is plenty of room for equitable design and inclusive participation. In fact, we've just come up with a recent report towards digital transformation of universal health coverage, where we really are beginning to document some of these things, where digital entrepreneurs and social entrepreneurs are beginning to reach out to the communities they serve, to be able to more intuitively understand their problems, but also to see what they're doing and where they're going wrong. I mean, a classic example is an Indian company that I work with, and they had a recent a conclave in a very remote area in the Sundarbans in India. And part of that conclave was to not only showcase some of the work that they were doing in screening for non-communicable diseases and maternal care in that region, but in that process, they also discovered they were actually replicating some of the work that the government was already doing. So part of this was a learning by doing. It was engaging with the local community to see what they needed, but also looking at the state to see where the duplication was happening and how better integration could really take place. But this is a slow process. It's not going to happen all at once. But really, as I said before, we have to begin this dialogue now. And even as researchers, I do wear a research hat. It is about interrogating these questions more carefully. It's about creating research agendas that really begin to ask these questions, not only of the technology providers, but also of the governments that employ some of these technologies or encourage them. It's about getting multilaterals to think about this more deeply, starting with a report that Dr. Mofokeng has come up with. So it's really a combination of many factors, and it's not too late. It's just the beginning. And the wonderful part is that this is the right time. Even as, I'll never forget, the other day I was walking across the street and I saw this giant banner which had an iPhone and said, your health data is yours to protect, Apple. So if Apple is going to be one of the largest aggregators of wearable health data, we better start having that conversation now, because it's not going to be long before Amazon begins to provide basic primary care, and other digital companies are bought over by the behemoths. And at the end of the day, our health, as Paula said, is our responsibility. And if we want to have these discussions, we have to come together, not to view the industry as a potential enemy, but to bring them to the table and say, we need to talk. And these are areas that we need to unpack in order for your design to be as intuitive and to be able to reach those communities who are the most vulnerable and who have the least power in these conversations. So it's really about shifting those power dynamics.
Shifting power dynamics. When you just said Apple says your data is safe in my hands or in your hands, it's really in their hands,
Yes.
right? And
Yes.
I think it brings us also to this question of privacy, you know, on the back end, and I'm going to circle back to Dr. Jeffrey. How then can data be misused? There's this large swaths of data sets. How can these be misused to either racially profile certain groups or bring even more inequity or harms to certain groups? What has been your experience and how you have been doing your work and what you've observed?
Yeah, I think on the issue of privacy as well as security, I think it's very important that we have very transparent systems because with transparency comes the issue of being able to hold people accountable. So in the case of Apple, if they say that your data is safe with them or in your hands, how do you know? How do you hold them accountable? Even if you're not coming from the technology area, how can an ordinary person trust Apple or any technology company that their data is always going to be safe with them? So I think we need some systems of governance that can be established independent of individual commercial entities. And these standards of governance can define some basic criteria for standards for privacy or security. And I think without that, it's very hard to be sure that privacy can always be guaranteed. And an example is with genetic data. So genetic data is interesting from the sense that when a single individual consents to share the genetic data, that decision not only impacts that individual, but also impacts everyone related to that individual. So that means if your sibling shared their genetic data in some database, then by proxy, you could be identified based on your siblings' consent. So how do you handle this kind of issue? The other issue is that privacy can also be complicated with the possibility that other things can be inferred about data, even if those things are not directly accessible in that data. So for instance, the case of Amazon trying to infer whether you're expecting a baby based on like your the stuff you're buying from Amazon. So there's always ways that some personal information can be inferred from information that doesn't appear to be so personal. So how do you handle these gray areas? So even if we say that, okay, it's fine for you to share this data because it's not considered to be personally identifiable, but somebody comes up with an algorithm later and then uses that information to infer your identity. And I think that means that in addition to defining privacy, we also have to come up with standards of what can we actually do with your data. So if you share your data, maybe there needs to be some barriers of what somebody can actually use that data for. Because if we don't have those standards or regulations, then it will be very hard to prevent misuse of certain data sets like genetic data.
Yeah, I just want to build up a little bit on that, thinking about the rights and the protections and the privileges given to individuals from the global north whose genomic data makes up a data set, and individuals from countries in traditionally known as the global south, places like, you know, Africa, South and Southeast Asia. Do they get the same protection? Do they get the same standards of care in ensuring their confidentiality and their privacy is protected? And in your view, do they get the same benefits of whatever comes out of, you know, the work that you do as a computational biologist, that the work that you and others do to develop, you know, medicines and so forth to address diseases. I'm very curious about that, to think about that balance and to think about where are the big data sets coming from, and are the benefits of digital technology impacting those who contribute the most?
I think currently when it comes to this issue of genetic data, so over 90% of genetic data that is in public databases is from predominantly white populations. And this is a problem because genetic data is essential to inferring risk to certain diseases, so risk to say cancer, as well as other illnesses like autoimmune diseases. And so if there's a heavy underrepresentation of genetic data from African populations, there's also an impact in the diagnostics that are being developed using genetic data. The other issue, of course, is that African populations are much more diverse than white populations. And so actually, if more genetic data is obtained from African populations, it can actually have an impact across all patient populations. So I think actually there's a missed opportunity there, because we all need each other when it comes to health. Health does not discriminate, even though we have inequities that then drive like inequities in health, but disease in itself does not discriminate who you are. Yeah.
Thank you. Paula or Dr. Priya, do you want to come in at all on that issue of genomic data and, you know, how we can make sure that there's equity in that area, or protection of privacy and confidentiality?
Yeah, I think.
Sorry,
go
Paula. Go ahead, Paula. I'll follow up.
Awkwardness of digital conversations. This has been a really hot topic, especially in the past couple of years. And it's partly also contributing to the proliferation of data sovereignty laws that are increasingly coming up across the region. I think for any kind of data sharing, whether it's genomic data, whether it's imaging, which is another important sort of data set that's required for AI, and even the syndromic data that's used to develop algorithms that can predict, for example, risk of disease, risk of mortality. In all those cases, I think that the general imbalances that are reflected in the broader global health sector, again, manifest. I don't know enough about the data protection laws in the US, for example, to make that comparison. But what I would expect is that while the protections might be the same on paper, in practice, I think there's a lot less accountability, there's a lot less recourse when it comes to how data is used or misused. At the state level, you see that governments are increasingly protective of how their health data is used, by whom, in what contexts. And one of the reasons for that is not just because of privacy, which applies at so many levels, but also because the products that come out of the insights, you know, based on this data are then often inaccessible to the same populations whose data inform their developments. And so you're essentially being, like many extractive industries, data is being taken to inform technologies, to inform new pharmaceutical products, which then you will struggle to access, even though your population was the testing ground in some cases. So it's definitely something that I think is more of a political than a technical question. Certainly, there's a lot of thinking these days. I know in conversations that I have been involved in, where data sharing keeps coming up, there's increasingly realization, both from, I mean, including from private sector, from manufacturers based perhaps in Europe and America, that they need flexible, they need federated models when it comes to how data is managed, because countries will increasingly not allow data to go outside their borders. So it's something that I think is workable, but there needs to be the political will to do that. And there needs to be, I think, just a lot of honesty about what it means in terms of the commodification of these products, in terms of the profit that can be generated when data is shared. And I'd also briefly like to make mention, when we talk about data, we often think about what is captured, how it's protected. I think there's also a lot to be said for what is not captured, what is not prioritized when it comes to using digital tools to capture data. One of the areas I worked in when I was in South Africa was around TB in the mining sector. And we don't have enough time to get into the details, but essentially a lot of what could and couldn't be argued in court, because those are large class action suit, came down to what could be accessed in digital databases. And sometimes there is a perverse incentive for certain types of data not to be made available, because it also then limits visibility into some social justice challenges. So I think what we don't know is also something that we need to consider. Thanks. Over to you, Priya.
I completely agree with the points of the other speaker, but I just want to kind of shift that needle a little bit to also say that a lot of data, whether it's is around where it's generated and who is generating it, and that balance can also shift. Right now, your question was around, where do we stand vis-a-vis the wider global north, where a bulk of these technologies have actually kind of emerged, including some of the big technology companies. That may shift. And that is shifting over the next couple of years. And what we are probably, if you're going to turn the crystal ball or the lens, a lot of that is going to now come increasingly from the global south as well. So at some point, there is going to be a generation of genomic data that is going to be produced from the global south, and that is going to include the racial characteristics of the majority of the population that lives in this area, whether it's Asia or Africa or a combination of two. And this is going to change, or will eventually change, how we begin to look at sharing data, and also how we collectively begin to look at how we understand data. Whether it's through a federated model, or whether the fact that interoperability doesn't really work. But at the end of the day, these models are also going to be about sharing networks and sharing information. It's not so much as protection, but it also has to be about sharing. And we've seen that as a result of COVID, what defensive strategies around data invariably did, and how countries kind of reacted with that. So I think there is an increasingly, thankfully, a more vibrant dialogue about these things around health data governance, for example, having a global standard that can be adopted by both the North and South or globally. There are conversations that are beginning to happen about how we begin to ask those big questions to the big companies. That, where does digital monopoly go in terms of data? And should data, or the governance of data, actually be autonomous? Because data, whether it's in the hand of a large company or a dictatorial government, can both be misused. So then, so I think these are fundamental questions that may not always have all the answers, but again, it's about beginning to ask these questions in the development of technology, in the understanding of technology, and in the understanding of how technology is going to shape the way we use it, not the other way around.
Thank you so much for that. Just as a parting shot, in one sentence, you have the co-chair here of the Commission on Racism. This is a commission that's seeking to really shake the foundations of global health and make global health recognize that it needs to come into this century, this 2023 and beyond, and have equity. What question would you want to see this commission respond and dig into and give recommendations for around data, racism, structural discrimination, and health? I'll start with Paula.
Oh, I was hoping you wouldn't start with me.
I know.
A profound question. That's a really profound question. And, there's always a bit of limitation in terms of what one can do within a specific sector. But certainly, I think having the I don't know if it's a question so much as what I would love to see happen is really.
It can be a question or what you'd love to see happen.
Yeah, so really having the recommendations in the same way that clinical recommendations go through a process, both technical and political, to get them vetted and really entrenched in how health programs are designed and delivered. I think having a similar thing for digital technologies would be great, and building that alignment across different groups would be a really good starting point towards these more granular challenges that have come up.
Great, thanks. Priya, what would be your ask for a commission tasked with such a big role?
I would love to see these recommendations find their way into implementation. And I would love to begin that with that inclusive approach of including citizens in that process to trust, and including the vulnerable and marginalized groups in this kind of decision-making process. And this is an organization that has the convening power to do this. And this is what I'd love to see the report translate to. I'd love to see that convening happening. I'd love to see these recommendations, these debates be reflected in the first of those kind meetings where race, structural barriers are openly discussed and the status quo is openly challenged. So I'd love to see that happening.
Great. And Jeffrey, you get the last thought on that?
Yes, I'm not sure that this is a particular question, but I'm wondering what role tech and technology people and academia can play in ensuring that there is like design justice. Yeah, I think that would be very very important in driving the conversations, so that when new technologies like ChatGPT, come out, it's not the whole world being like driven by this new technology that the world never shaped, but now the world is like figuring out what should we do about ChatGPT. So what's the role that tech and academia can play?
Okay, wonderful. Thank you so much to our panelists. Thank you for your insights. Thank you also to Dr. T for the report that you produced and the conversations that it's sparking and hopefully will continue to spark. Thank you to all the audience members that joined us. Some of your questions have already been asked. Please feel free to visit the website for the Commission if you want to register for updates on the work of the Commission. Thank you, everyone, and have a good day.